Hello, everyone, and welcome, and thank you for joining us today. We're joined here at Contagion with a familiar face, Dr. Jason Gallagher. Dr. Gallagher, if you don't remember, is clinical professor at the Temple University College of Pharmacy and Contagion's editor-in-chief. And Jason's joining us today to talk about something that me and him last talked about a month ago. And there's been a lot of developments within for COVID care, which is Remdesivir. First and foremost, Jason, how you doing?
I'm doing okay. A month. Wow. A month in 2020 terms is easily a solid year in 2019 terms.
Yeah, in quarantine terms, I had a full head of hair when we last talked about Remdesivir. So
My wife cut mine for the second time now yesterday. I think she did
wow,
okay.
you went back for it. Looks better than mine. Props to her. That's great. So obviously, we had some new data come out of NEJM yesterday for Remdesivir, looking at a 400 patient trial global results. But before we get into that, I thought it'd be great with it being such a time-stamped moment, with it being the last time we talked about it being late April, and Remdesivir having not even received emergency authorization, and that being the topic of a discussion we had then. That'd be good to just touch back on that. And Jason, something you told me at that time is, a prediction that you had that trial enrollment rates would be affected with the drug becoming more readily available by the FDA. And obviously the effect of placebo comparison rates in these trials also being affected. Could you catch us up now and tell us, has it been affected?
And that's a good question. I truthfully don't know. I can say from our own standpoint, well, fortunately, since we last spoke, our number of COVID patients has come down considerably. We still have, we kind of did a dip as the city and state have done overall, and then plateaued a little bit. And we're hoping for it to curve further down. But we still have been able to enroll a substantial percentage of our patients in clinical trials. It really hasn't prevented that. I don't know what that situation is like at other places. So, and truthfully, after that happened, then we had to wait for a drug to be available. It's only been a fairly short period of time where we've really had, Remdesivir in the emergency use authorization to utilize at all after some, interesting early rollout hiccups.
Right. And that's actually what I wanted to ask you about next, if we can just feed right into that. What has the supply been like since the authorization has been given?
So the way that the government seems to be taking care of it is to roll it over to the states, which is probably a pretty good approach, I think, in my opinion. And then the states have all taken various, approaches to that. Pennsylvania's is publicly available, which I think is very important. Put it out there and let people see. And for the first rollout, I'm going to call it round one, vials of Remdesivir going to hospitals. They had a list of 50-something hospitals in the state in an Excel spreadsheet, the number of COVID cases that they had over some period of time. I don't remember it off the top of my head. The number of intubated patients they had with COVID, and then came up with some magic formula of basically the percentage of the vials available and which hospital would get it. And I think that it's not a perfect system. Obviously, the hospitals could argue about it, but it's pretty transparent. And since Temple was pretty high on that list, I guess I'm at least happy on how it has gone. But the number of vials that came out from that first round were still pretty small in number. And then a second round has occurred, and from a supply standpoint, we're okay, knock on wood, at least right now. So that's been Pennsylvania's approach. I have no idea what it was like, beyond that. And before it was turned over to the states, it really was fairly chaotic. There was a really big backlash against, why didn't we get it? We have the most cases here. We have the most cases here. And some hospitals that had these very high demand didn't get any supply. So turning it over to the states, I think, was a good move. Again, I can't speak for what other states have done. I can speak for friends who I know have been involved in the distribution for their own states. I'm quite happy to let the state of Pennsylvania do that one on its own.
Yeah. Dr. Galler, just wanted to ask about something else that you had mentioned back before the emergency authorization was given in late April for Remdesivir. Obviously, NIAID came out very early and very strongly in support of the drug's capability and potential in treating hospitalized patients. And this, not to quote back to you, but what you had said at the time was that it had better be as good as it had been said already regarding Dr. Fauci's own comments as to what it could mean for COVID patients. And obviously at the time we're in a position where we could have used a lot of optimism for some of the candidates that were coming out. Do you think it has lived thus far up to the promise that supporters like Dr. Fauci have put behind it?
I think even he has walked back a little bit, from, I guess it wasn't even so much him, but the way that people took his comments. I think what I was saying was that, once you say we've got a new standard, I hope we do, because now everyone's going to hold you up to that. And I do think that Remdesivir is not a grand slam. It's not even a home run. You know what I mean? It's like a blooper out into left field that gets you on base. It has efficacy. I believe that from the study that, the studies that are available now, that there's 3 of them. We didn't see mortality benefit in one very underpowered study. And then the NIAID study comes out, no mortality benefit there, almost, but not quite. Maybe I'll move it up to a double. And then, this most recent study, which was not looking at efficacy, looking at the 2 durations. So at least data is coming. It's nice to look at published data now instead of just going preprint by preprint. But if the way to answer your question is, does the study that was published, the NIAID study, measure the hype or the tone or context of his remarks? I think it does. Like you said, it's the first drug. It's not the last drug, hopefully, and it's a start.
Yeah. And speaking of it, the trial you're referencing to is the Act 1 trial, which had preliminary results come out on Friday, about 1,000 patients across 10 countries. Do you want to just highlight, Jason, what you found to be, I guess, the most impactful findings that come out of that, or just the big take-home message?
Yeah, I think there was a few, actually. I think it's a pretty digestible study. It showed, as he had alluded to earlier, that patients that got Remdesivir had a shorter time to improvement than patients who didn't. But, this is one where the devil's in the details. And I think there was one negative set of details and another surprisingly positive one. Looking at the kinetics of the virus, it really makes sense to me that this drug would be useful early in the course of disease, and possibly useless later. But that didn't come out of that study. There was no difference between the patients that had it started within 10 days from their symptoms starting or afterwards. And I have to admit that caught me completely off guard. I think that's good. I'm glad that we're not going to be, nailing patients down to, are you sure when those symptoms started? Because I always think those things are difficult anyway. And truthfully, that may even be a failing of the study. Who knows how specific they were really able to get people down to it. So I think that's good that we know that it's not just useless if it had been further into their symptoms, as are sometimes, the case with some other antivirals. Less hope, though, for the patients who are the most sick. So, patients receiving supplemental oxygen and not on high flow nasal cannula or non-invasive mechanical ventilation or ECMO or mechanical ventilation were the ones who benefited the most. So I think for our sickest of the sick patients, Remdesivir is just not going to be our answer. I mean, in those higher risk categories, there was essentially no effect, particularly in patients on mechanical ventilation or ECMO. I think for those, we will have to be looking towards therapies that move beyond just targeting the virus, and those are being investigated now.